Your mother was fine yesterday. Today, she's in an intensive care unit. There's a breathing tube, there may be a drain coming out of her head, and a rotating cast of doctors keeps saying words at you. Coiling, clipping, hydrocephalus, vasospasm, and then they may leave the room. I'm gonna tell you what the first 72 hours actually mean. Not the textbook version, the version I'd give you if you pulled me aside in the hallway. I'm Dr. Richard Dalyai, I'm a vascular neurosurgeon. I treat ruptured brain aneurysms, and I have this conversation with families several times a month. I've never once had a family walk in already understanding all of it. So here's what I'm gonna cover. What actually broke? What do we do in the first day? What that drains for? Why the ICU won't let her sleep? And why nobody will give you percentages. And stay to the end because I'm gonna give you 5 specific questions to ask her team tonight. The same 5 I'd ask if it were my own mother. One thing first, this is education, not medical advice about your mother. I'm not her doctor. Everything here is meant to help you understand her team, not replace them. Before anyone can explain the treatment, you need one distinction. Almost every confusing conversation you're about to have comes from these two things getting blended together. An aneurysm is a weak spot in the wall of the artery. Over time, that weak spot balloons outwards. Think of a worn place on a tire. When it ruptures, blood escapes under arterial pressure into the space that surrounds the brain, the subarachnoid space, which is under the membranes that cover the brain. That's why a very small aneurysm can injure the entire brain. It's not the size of the aneurysm, it's the pressure and the amount of blood that leaks out. So the aneurysm is the source of the bleeding. The subarachnoid hemorrhage is the injury that the aneurysm caused. Now hold on to that because it explains the sentence that confuses families the most. Securing the aneurysm prevents another bleed. It does not erase the injury that already happened. That's why you can be told the surgery went perfectly and still your mother might not be fully awake. Both things are true. The first few hours answer 2 questions. Is she stable right now? And where did the bleeding come from? First, breathing. If she's not awake enough to protect her airway, she needs a breathing tube. I want to be straight with you about this one because it's the image that stays with family. A breathing tube looks like she got worse, but often it means we decided not to wait until she did. It helps us control her oxygen when she's not awake enough to control her airway. Next, blood pressure. Before the aneurysm's secured, we want to lower the risk of another bleeding, keep the blood pressure low. We'll ask you about blood thinners, which one, and when she last took it. This is one of the few moments where a family member can genuinely change the medical care. Some medications like warfarin we can reverse quickly. Others like Plavix may need a platelet transfusion. If you don't know, say you don't know, and then go check her pill bottles, her pharmacy, her phone. Then imaging. The first scan is the CT scan without contrast. It shows where the blood is, how much there is, and whether the fluid spaces in her brain are getting larger. Usually we follow with a CT angiogram, which is dye injected during the CAT scan, which shows us the aneurysm itself and the arteries around it. And if she's not already in a hospital with a dedicated neuro ICU and vascular neurosurgeons who do both open and catheter-based aneurysm treatment, transferring her is part of the emergency treatment, not a delay in it. Now the clock starts, because until that aneurysm is closed off, it could bleed again. And a rebleed is often devastating. That's why current guidelines say to treat a ruptured aneurysm as early as feasible, ideally within the first 24 hours. There are 2 ways: coiling, where I thread catheters through an artery, usually at the wrist or the leg, up until the vessels of the brain. And I pack coils inside the aneurysm so blood can't get in. Some aneurysms may need additional devices. Clipping, I open the skull, work under a microscope, expose the aneurysm, and then I place a clip across the neck. Blood keeps flowing through the normal arteries, it just can't enter the aneurysm anymore. Families often always ask me, isn't coiling less risky? Because it sounds safer. There's no big incision and we don't have to work through the skull. And the answer is not automatically. The right answer depends on where the aneurysm is and what shape it is. With newer devices, we can treat more ruptured aneurysms through the catheter, especially more than we used to. But the goal isn't to get one particular operation. The goal is to be somewhere with a team that can honestly do either one. And that picks based on her anatomy, not on what they're comfortable with. And then the part that's hard to hear. Securing the aneurysm closes the source. It doesn't remove the blood that's already out there, irritating and injuring the brain. Getting through that procedure is a real victory. It just isn't the end. There's another problem we often deal with, even before the aneurysm, and it's usually the first thing that families may see. The drain coming out of her head is called an external ventricular drain, an EVD, and it is the most alarming looking thing in that room. And it's treating one of the most reversible problems the hemorrhage caused. Her brain constantly makes a fluid, cerebrospinal fluid, CSF. It circulates through connected spaces inside the brain called ventricles. It flows around the brain and the spinal cord, and it gets reabsorbed. Production never stops. After a rupture, blood gets in the way way. It can fill the ventricles, block the channels the fluid moves through, or it could keep it from being reabsorbed. The brain keeps making the CSF. The fluid has nowhere to go. It backs up, the ventricles enlarge, and the pressure builds inside the skull because the skull can't expand. That's hydrocephalus. What you see is her getting sleepier, not following commands, less responsive, sometimes needing a breathing tube. And here's the generally difficult part. The original hemorrhage causes those exact same findings. So does sedation. So when she's not waking up, we have to work out how much is the initial injury and how much is the intracranial pressure building up. That matters because one of those we can treat quickly. So we place an EVD, a small catheter through an opening in the skull into one of the ventricles, draining CSF into a closed system outside the body. It does two things. It lets us measure the pressure inside our skull, and it lets us treat that pressure by draining the fluid off. Sometimes the change is dramatic. Someone who is barely opening her eyes starts following commands, and that tells us how much of what we were seeing was due to the pressure. Sometimes it barely moves the needle. If the original bleed did more damage, or she's sedated, or seizing, or swelling, the drain's not going to fix that right away. One practical thing, and please take this seriously, that collection chamber beside the bed is leveled at a specific point next to her head, and the height controls how much CSF drains. The nurse clamps the drain before turning her or changing the height of the bed. Never move that chamber, raise the bed, or handle the tubing yourself. Ask every time. Over the coming days, the team works out whether she could handle her own spinal fluid again. Some patients get the drain out. Some develop hydrocephalus and eventually need a permanent internal shunt. That's not a decision for the first day. The aneurysm is secured, the pressure's controlled. It feels like the emergency should be over. And it is a milestone, but she's still recovering from the blood that's already out. And several of the things that can go wrong next are treatable if we catch them early. That's the entire reason she's still in the neuro ICU. Which brings me to the thing families find the hardest to tolerate. The nurse will wake her up over and over. Name, place, squeeze my hand, lift both your arms, wiggle your toes. She'll finally fall asleep and someone will wake her up again. And you'll want to throw the staff out of the room. Please don't. The exam is the monitor. There's no machine in that room better at catching a treatable problem than watching what she can do, checking it against what she could do an hour ago. If one arm gets weaker, if her speech changes, if she's harder to arouse, we want to know that immediately. Everything else on those monitors protects the same thing: blood pressure and circulation, enough flow to deliver the oxygen to the injured brain, with no single perfect number for every patient. Sodium in fluid, which is subarachnoid hemorrhage, generally disturbed and which can cause confusion or seizures when it drifts. Fever, oxygen, blood sugar, heart and lungs. A severe hemorrhage can temporarily affect the heart and lungs, which is why there's a cardiac monitor and maybe an echocardiogram on a patient. Seizures too. Some are obvious, some are only a subtle change in awareness, which is why we sometimes use continuous EEG. Not every patient needs anti-seizure medication long-term. And one medication you'll see given religiously is called nimodipine. It's given on a strict schedule because it improves neurological outcomes after aneurysmal subarachnoid hemorrhage. And it reduces the impact of delayed cerebral ischemia. It can lower her blood pressure, so the team has to balance between the two. Every one of those numbers is asking the same question: is the brain holding steady or is something treatable started? At 72 hours, families ask me the same thing: are we out of danger? 3 days is a real milestone. The aneurysm is secured, the hydrocephalus is controlled. She may even be awake and talking to you. Honest answer is no, because the first 72 hours hand off to a different high-risk period. The blood that escaped is still sitting around the arteries on the surface of the brain. Over the days that follow, those arteries can narrow. That's called cerebral vasospasm. When the narrowing cuts down the blood flow enough, part of the brain stops getting what it needs, and that's delayed cerebral ischemia. It can become a stroke and a new lasting neurologic deficit. The risk starts to climb around day 3 or 4 and stays a concern for roughly 2 weeks after the bleed. So if she's awake, that neurological exam is still the best tool we have. New weakness, trouble finding words, more confusion, more sleepiness, that may be the first sign part of her brain isn't getting enough blood. Although hydrocephalus can come back, sodium can fall, a seizure or an infection or medication, low blood pressure can look exactly the same. The exam still tells us something changed. It doesn't tell us why. We still have to figure that out. If she's intubated or can't reliably follow commands, we lose that tool and lean harder on testing. Transcranial Dopplers or ultrasounds that show how fast the blood is moving through the arteries. CT angiography, CT perfusion, EEG, sometimes catheter angiography. I want to address something directly, because I know how it must feel from your side of the bed. When you ask whether she's going to be okay and the team gives you a careful non-answer, it can feel like we're hiding something or just not listening to you. We're not avoiding the question. We're refusing to give you a confident answer because we don't know the full story yet. And there are a spectrum of possible outcomes. Here's what we're actually using. We start with how she was when she arrived or after the EVD. Awake and following commands, confused, or in a coma. That one fact carries more weight than almost anything else. The imaging, how much blood and where it is, blood inside the ventricles, hydrocephalus, areas of infarction, meaning brain tissue that's already dead, widespread swelling. And then the part that matters most and takes the longest, the trajectory. Not where she was, but where she's moving to and the direction. Is her exam improving, holding, or slipping? Do we have new problems? Delayed cerebral ischemia can change that picture a week after the bleed, and her heart, lungs, kidneys, and infection can feed back into whether her brain is recovering successfully. That's why no single exam, no single CT scan can often tell you exactly how this will end. And it's why a statistic you found at 3 in the morning doesn't really describe your mother. It describes a population, and she's not a population. If you're living through this right now, here are 5 questions worth asking. Write them down. Ask them at rounds when the whole team is standing there. 1. Has the aneurysm been completely secured? Or is any part of it still untreated? And are there other unsecured aneurysms? 2. Was the aneurysm that ruptured coiled or clipped? And why that choice for her? The answer should be about her anatomy and her condition, not because that's what people usually do. 3. Does she have hydrocephalus? And does she need a drain? If a drain is already in, ask how her exam has changed after it went in. That answer tells you a lot. 4. What does her neurologic exam show when sedation's lightened? Ask what she can do consistently. Can she follow commands? How much of her exam is related to the medication? And is her exam improving, stable, or worsening? 5. How will you monitor for delayed cerebral ischemia over the next 2 weeks? That means frequent exams, transcranial Dopplers, and closer monitoring if her exam isn't reliable. At 72 hours, the source of the bleeding may be controlled. Now the team is watching for the delayed effects. So let me leave you with something you can actually do. Because sitting in a waiting room feeling useless is its own kind of injury. Tonight, write down her medication list, especially any blood thinners. Write down those 5 questions. Pick one family member to be the point of contact for her team. 1, not 6. And sleep in shifts, because a useful version of you is the one still standing in 2 weeks. Some answers come quickly. Recovery usually doesn't. If this helped, subscribe. I'm making one of these for every conversation I wish I had more time for in the hallway. And if you're in it right now, I'm sorry. Go be with her.